Good afternoon, everybody. My name is Dr. Badar, and I am the section head Neurosurgery here at Badar.ujjan. Today we are going to discuss an important topic in the neurosurgery, which is the core neurosurgery topic related to the congenital disorders, of the neural tubes. So, neural tube defects. One can define it that the closure of the neural plate, which you would see in the upcoming slides, that the neural plate fails to close at its expected normal time. Means the normal time to be closed for the neural plate is delayed. It gets a bit late in the closure of the neural plate, so it causes the neural tube defects. If we see that the neural tube defects, its incidence is so high that a well-developed country like America, the live birth is around 1 in 1,000 baby have some issues related to the neural tube. So you can imagine that how common it would be in the countries who are developing, like developing countries like Pakistan, like our country. So in this slide, there are 3 pics. In the topmost, you can appreciate well. This is the neural plate.
Hello.
Ji. Is everybody listening these things? Hello.
Hello.
So the neural plate, in initial duration of the time, it's straight, but with passage of time, its ends and parts become fold, and the plate takes the shape of the tube. So it is expected to be closed at its expected force. One is at the upper part of the body, and other is at the lower part of the body. So you can call it a cranial, and another is the caudal. So the cranial or upper neuropore gets closed on the 18th day of the development, while the it appears on the 18th day and gets closed on the 24th day.
Hello.
Gets closed on the 26th. There are different etiological factors. They may have the family history, and there may be teratogenic drugs or any exposure to the radiations, and any disease infection during the conception period, like herpes or other infections during the child bearing age duration, they can cause these defects. And it is assumed that folic acid has significant role to prevent these effects, but still we don't have its evidence, or it's not so evidence-based. While the risk factors, if a woman who has delivered a child in her previous pregnancy with neural tube defects, she may have risk more than 2 to 3 times than a common woman to deliver another child having these neural tube defects. So the previous pregnancy is the main risk factor. There may be, as I described, that there is significant risk if there is family history. And type 1 diabetes is assumed to be a risk factor for the development of the neural tube defects. Few patients who are taking an anti-epileptic, so epival or valproic acid for seizures, it can.
Sir, आपकी voice clear नहीं आ रही.
Women are there. There are 2 types of these neural tube defects. One were the open, and other are the closed. So if you see, the open are the most common type of the neural tube defects, and in these a child can present with a spina bifida, anencephaly, and encephalocele. So spina bifida, anencephaly, and encephalocele, they can present with these are the defects. And the closed is the rare type. And in closed, there may be lipomeningocele, lipomyelomeningocele, and tethered car, spinal tethered car. So spina bifida, one can say from its name bifida, means division in two parts, means that spinal part or spinal column would be divided in two parts. So spina bifida, either the bone would be open, or skin, or whole spinal column, or spinal cord itself. So it's after this theoretical description of the neural tube defects, you can further understand when we come towards the pictorial part. In figures and photos, you can well differentiate between these different types. Although its terminology is difficult, but when we come for the pictorial presentation, it will make easy to understand these things. So spina bifida. Spina bifida has two types. Again, it has closed and open type. So spina bifida occulta. Occult means closed. So there would be defect, but these things would be covered. And it is the commonest in migraine form. And other is the spina bifida cystica, that is open. So meningocele and myelomeningocele, they come under the term spina bifida cystica. So from this pic, you can understand it in better way.
सर आवाज सही नहीं आ रही है आपकी.
अब आ रही है?
नहीं सर.
अभी? हेलो?
जी सर बोलें.
अब आवाज आ रही है?
सर कम आ रही है बहुत. मार्क्स उतार लें अगर उतार सकते हैं तो.
एक सेकंड. अब आ रही?
जी सर बेहतर है.
चलें. So in this diagram, you can appreciate it well that how spina bifida occulta and cystica can present. So in occulta, although these bony elements are divided in two parts, ideally the bone should be covering from this to this part in normal situation. But when it comes to bifid spine, spina bifida occulta, so here the bone elements from this part would be they would be absent. Spina bifida occulta. Aside from absence of these bony elements, there wouldn't be any other abnormality. Here this is the dura, and here is the spinal cord. So they would be at their normal place and in normal position. Only the posterior elements would be absent. Otherwise, it's the patient, the back of the patient and other things, you would see any obvious deformity. In spina bifida cystica, these both come meningocele and myelomeningocele. Aside, additional to the bifiding of this spine, the dura is stretched out, so it would present with a swelling, significant swelling at the back. So here the dura is not at its normal place. Here the dura is stretched out through that defect. that bifida spine. So the dura and CSF, they are stretched out, protruded out that space in the spine because of its bifidity. This is its severe form, meningomyelocele or myelomeningocele, you may call it. So myelo means spinal cord. So here only nerves and CSF will be out from its normal position, would be protruded out, making some swelling at the base. But here, spinal cord itself becomes exposed. It becomes part of the swelling. So when the spinal cord is protruding through the defect, protruding through that place, so you can imagine there would be damage, there would be more risk of the deterioration of the neurological function in this patient. Where in these both patients, the neurological deterioration is very less. As in this slide, I mentioned that the vertebral arches or the vertebral bone covering that spinal cord or spinal nerves is that place. So because of its deficiency, these nerves, CSF, dura protruded out through that defect or that through that defect. So that child can present with issues related to loss of or impaired control of the bladder and bowel functions. He or she with weakness of the feet, weakness of the legs, thighs, and along with weakness, he may have inverted feet like T-lips equinavera, and although the sensations have gone, so he can present with ulceration of the feet. And there may be bony spur presenting between the cord parenchyma from passage of the cord. The normal passage of the cord can be interrupted in between by the bony spur. So that would be called the diastometomyelia, means diastometomyelia. Di means two, metomyelia means spinal cord would be split in two parts by the bony spur. Otherwise, as I in previous slide, everything is at its place. So there would be no significant swelling, but there may be some changes over the skin, like any black spot, hair, or any sinus they may present, or redness at that area. So in spina bifida occulta, there is no protrusion of the cord, there is no protrusion of the nerves, so patient apparently does not have any issue. So majority of the times it is incidental finding while nursing of their baby by their mothers. They appreciate some defect, like some deformity at the base without any neurological deficit. Because families get worried when their child has some issues like movement of the limbs, lower limbs, apparent swelling. So apparently patient does not have significant issues related to the neural functions. So they notice these things. These things are noted either incidentally or in the late stages of the life. So here you can appreciate well the posterior part of bone is absent, but here, hair, and spinal cord, subarachnoid space, everything. In X-ray, the normal AP, this is also AP view. In AP view, we can appreciate. So this is the posterior spinous process. Here is the lamina. Here is the facet. So lamina, posterior spinous process, lamina, and facet. They all are normally developed. But here, if we see, the posterior process is partially developed, lemna is partially developed, and this is the defect. So on X-ray, you can appreciate it in this way: spina bifida upper. So the absence of the bony elements can be appreciated well at this stage. So as I told that they may have tuft of the hairs at the dorsal or lumbar area. Coming towards the other neural tube defect, that is encephalocele. As spinal part, the myelomeningocele, the severe form, and in the cranial part, the encephalocele is the severe form of the neural tube defect. And majority of these kids die in their early days. Very few of them survive, otherwise they all die. So this is although most common CNS malformation in Western world, and as I told, that majority of the children die in their early stage, and if there is previous history in the family, so there would be significant risk in the future for their family. So basic idea is same. Either it would be cranial or it would be caudal. The basic idea is same. There would be deficiency of the normal structures covering these organs like brain, like spinal cord. So in the cranial neural cord, definitely it would be the upper spinal cervical region and the brain. And where is the caudal, the thoracic and lumbar. So whatever bony parts, skin, soft tissue covering that structure, they would be deficient. So when talking about the cranial, so there would be the less development of the defected development of the cranium over the brain. These child have different variety depending on the types. So the level of fourth year, you should know just mechanism and types, major types, not the special types of the cranial defects like so whole cerebrum or whole brain tissue would be absent. Here you can appreciate the cranium above the level of the eyes absent. In later view, you see the forehead, but no. This is another tip of NN. NN means absent. Cephaly means brain, absent brain. So during before delivery, they can present with polyhydramnios, and if we do ultrasound before delivery, so they can show, they can detect that anomaly, and they are not compatible with life, so they have no any treatment. If they survive for a few hours, for days, so we give them just comfort care, no any specific type of treatment. Here the encephalocele. Encephalocele is as the anencephaly was we discussed that is more common in the Western. The encephalocele is most common in our country like Pakistan, India, and developing countries. So again, basic idea is same. There would be defect, and there would be protrusion of the brain. Yes, there was defect, but along with this defect, there was no development of the brain. Except defect, because it was open. The cranial neurophore was open, and there was no development of the brain. Here, the development of the brain would be there, but there would be defect, and protrusion, either that brain part or CSF would be there. If that brain is brain along with CSF is protruding through that defect in the cranium, that would be called, we will call it encephalocele. Means cephalocele means seal means swelling or cyst. Cephalo means brain. So there would be presence of the brain tissue along with CSF in that defect. In that state, we call it encephalocele. And if brain is at its normal place and brain is not protruding through that defect, then we simply call it meningocele. As in spinal part, we call this myelomeningocele when cord was coming. When cord was not coming, just we were calling it meningocele. So in brain, and then we can call it meningocele when brain is not coming. But when brain is coming there, it would be encephalocele. So you can appreciate well-walled development, but along with a huge cyst. Here, huge cyst containing some part of the brain and CSF. So this is encephalocele. Depending upon the location, that encephalocele has been divided or categorized in different types. If here it would be occipital, if around the nose and base, there would be basal, and depending upon its location. So occipital, frontal, temporal, you can see. You can say these like terms. But when it is frontal, when it is frontal, so basal. In the frontal, it is most basal, and there are other varieties. So you just remember that frontal, occipital, and these types. So here you saw it was occipital. Means occipital bone was deficient. The brain got protruded through that opening, also CSF. Same pattern, same mechanism, but it is at the frontal part. During intrauterine life, it can be diagnosed on the basis of the alpha-fetoprotein, AFP. We can take the sample of the amniotic fluid by amniocentesis, either from, if it is not confirmed, initially we go for the maternal blood. But if in maternal blood, alpha-fetoprotein is normal, but ultrasound is suggestive of some swelling, some anomaly in the child. So ultimately we go for the amniocentesis. So we take sample of the amniotic fluid and see the levels of the air. So myelomeningocele, spinal cord would be deficient. Spinal cord, nerves, and CSF would be coming out through that defect. So when like encephalocele, brain was coming, in myelomeningocele, the spinal cord and nerves would be coming out through that defect. So in a patient who has myelomeningocele, he may have associated other developmental deformities. He may have cardiac, chest, bone, and renal issues. is I have been repeatedly mentioning that when there is protrusion of the only dura or only CSF, then यार कुछ स्टूडेंट ने ना अपने वीडियो ऑन किए हैं, तो आप बंद करवा सकते हैं. अजीब गरीब दे आते हैं. हेलो. So spinal cord and nerves would be protruding through that defect. And definitely when the spinal cord is at rest, so they would be presenting with a neurological deficit. From this photograph, you can again understand it clearly. So this is the vertebral body, this is the back. So here only dura is protruding out, otherwise spinal cord and nerves are at its normal level. So this is meningocele. Means only dura or CSF protruding out through that defect. Whereas the spinal cord and nerves, they are at same place. This is the meningocele. When the spinal cord itself and its nerves gets out and protrude through that defect, that is the myelomeningocele. The spinal cord and nerves protruding out that defect, that is myelomeningocele, and only dura and CSF without protrusion of the nerves and the spinal cord, that is the meningocele. And here would be the gross appearance of that value. So you can better understand. So depending upon its type, it can present with the weakness of the legs, weakness of the bladder wall control, and if it has already got tethered, it can present with the scoliosis or the kyphosis. There may be associated with unrolled carry motion. Type 2 anal malformation is mostly associated with this. Type 2 anal carry malformation. So again, same pattern of the diagnosis: alpha-fetoprotein level and polyhydramnios, and at birth the clinical findings. So meningocele, as I have repeatedly defined, that only meninges, no neural tissue is affected. That is meningocele. The spinal cord, nerve, if they herniate, they will be myelomeningocele. They are not protruding through the defect, this is meningocele. In the meningocele, it is mostly the cosmetic issue. The functions are graphed. On examination, there would be no significant variation. There would be no significant anomaly related to their function. And I previously told that the meningocele or myelomeningocele may be associated with carry malformation. And another question examiner can ask that with carry malformation. The most common association is with carry 2 malformation. This is the tip of the meningocele. When with that CSF fat content is present at 4 meningocele. Along with CSF, spinal cord, and fat content is present, we will call it lipomyelomeningocele. So, only protrusion of the dura, CSF, plus additional presence of the fat contents, it would be lipomeningocele. But along with protrusion of the spinal cord, nerves, CSF, there's presence of the fat over there, it would be lipomyelomeningocele. So you can appreciate this fit and this fit differentiate. That's why we are calling it spina bifida cystica and calling this spina bifida occulta. So, with lipomeningocele, the overlying skin would be normal. The skin covering that swelling would be intact. There will be some alteration, but the lastly skin would be present in its normal form. So, before managing these developmental deformities, their families are counseled in details because these kids may need multiple surgeries. They may need multiple surgeries, multiple visits to the hospital, and aside from neurosurgery, they may need attention of the plastic surgeon. Some, if they have cardiac issue, so cardiac surgeon, cardiac physician or surgeon or a urologist. So before starting their treatment, we counsel them in detail that you have to adopt this pattern for this treatment. And this child may need multiple surgeries and multiple visits to the different specialties. So, treatment of the myelomeningocele. We just at the level of the fourth year, you don't need to go in detail and read the stages of their surgery, complication of their surgery. You just say repair of myelomeningocele, nothing more than that. In that repair, we take a spinal cord as a synopsis, develop proper dural layer, close it, and repair the defects in very better way. If the overlying skin is deficient, we can close it with rotating defect. So, at the level of your stage, you just say only repair of myelomeningocele, repair of meningocele. It is more than sufficient. These child may have associated hydrocephalus, or hydrocephalus may be isolatedly present, but there may be association of the 10 to 20% cases there would be hydrocephalus. So for hydrocephalus, they may need ventriculoperitoneal shunt. Here the term external drain or extra, sometimes they say EDO. So that is placed when there is blood in the ventricle. When there is infection, then we put that temporarily external ventricular drain. Otherwise, it's proper the insertion of the ventriculoperitoneal shunt. So, issues related to the bladder, kidneys, cardiac, they may be treated by their related specialties, by their related surgeons. In this related, if there are issues of the bones or joints, they would be definitely seen by the pediatric orthopedic or pediatric urologist or pediatric cardiac surgeon. So, as I told before, the management of these neural tube defects, that child and his family or her family is bound to visit multiple times because of that issue to different aside from that neurosurgeon. So, counseling is the important factor when you are going to manage a child who has neural tube defect. Repeated follow-ups. You need repeated visits of that patient. And along with their follow-ups, you educate the family of the patient, mother, father, to take their special care, especially of their leg. If we have so take care of the if there are issues related to the urine, so special care of the police catheter. So there's no CSF leakage, we can wait. But now these are recommendations that if these child are operated in their early stages, so there are more chances of the child who were operated in later stages of life for the development of the bladder and bowel functions. So around 7 to 10% difference in the functions of the bladder and bowel was seen in the children who were operated in the early stages for the meningosis. Their functions were better than the children who were delayed and their surgery was done a bit later. So the purpose of surgery is to ensure that their functions shouldn't get deteriorated, and if the skin overlying that swelling or that cyst containing CSF gets ruptured or gets leaked, there will be more chances for the infection. So the treatment of the meningosis, if any examiner asks what is the treatment of meningosis, so it's straightforward answer is surgery. Its treatment is surgery. So the purpose of surgery would be to limit the deterioration of the neurologic functions, easy nursing, easy feeding, easy care by the parents. Because with their huge swelling, it would be difficult for mother to feed. It would be difficult for mother to give birth to their children, to handle them in supine or different positions. So if that swelling is excluded, it will be very easy for them to nurse their child. So there would be significant nursing issues if the operation is delayed or we don't do any surgical intervention. So previously, as I told, that the straightforward answer is the repair of meningocoel, repair of the myelomeningocele. But when terms come the lipomeningocele, then you may say that repair of myelomeningocele along with removal of that fat contents, along with removal of that lipoma. We call it lipoma. The fat contents are fat tissue adherent to that card at that area. We call it lipoma of the card. So we can say repair of lipomeningocele along with excision or removal of the lipoma. So whenever any family who has previous history of the neural tube defects and they are planning for another child, they need a detailed counseling. They need frequent visits to their primary gynecologist to take proper diet, to take required ingredients, vitamins, and these associated supplementary things like folic acid in their life before conceiving their child. If any lady who has previously delivered a child with neural tube defects, they need more folic acid dosages as compared to the normal people, as well as before going for conception, they may need folic acid administration around 4 or 6 weeks before they are planning it. So thank you for listening and hearing this boring topics, although we try to make easy for your listening. Thanks. Hello.
इधर एंड बोलो
जी जी
ठीक है
ओके थैंक यू